Good morning, everyone. Thank you very much for joining with the Young Physicians Forum. So for the month of March, we have two presentations, and the Young Physicians Forum is sponsored by CIPLA as usual. We are thankful for their support. And this will be followed by the college lecture after the two presentations. For the presenters, I just announcement that it has to be finish your presentation within 25 minutes, and 5 minutes should be allowed for questioning. And I will sort of, if we are going, not finishing by time, I'll just give a notice to before 2 minutes to wind up the presentation. To start today's presentation, I'd like to invite Dr. APCP Lankaratne, Senior Registrar in General Medicine from the Professional Medical Unit, National Hospital, Sri Lanka. He will be talking to us on hypertensive emergency, a critical evolution to what went wrong. Over to Dr. Lankaratne.
Thank you, sir. Dear sir and madam, and my dear colleagues, today I'm going to present on this Young Physician Forum. Topic is hypertensive emergency, a critical evaluation into what went wrong. One of the interesting topic. I'm Dr. Lankaratne, Senior Registrar, representing Professional Medicine Unit, National Hospital, Sri Lanka. At the beginning, I would like to thank CCP giving us this opportunity to present this kind of forum. So, first of all, let me ask this question from the audience. Do you know about hypertensive emergency? I'm pretty sure our answer is yes, but let's find out at the end. So this talk was basically based on this interesting documentary called Air Crash Investigation, that is a Canadian documentary. What they do, aviation authorities, when there is a plane crash happen, even single crash, they evaluate and they investigate into what went wrong, and they find the answer and fix it in order to prevent future crash. So this outline of my talk, I would go with definition of hypertensive emergency, pathophysiology, epidemiological data, and cause precipitating factors, and how to evaluation a case of hypertensive emergency, and what are the gray areas in hypertensive emergency, and at the end, the references. I would like to begin with these two case scenarios. Recently, myself, I came across. Case number one, 30-year-old gentleman who present with the past history of renal impairment, presented to us with the 3 days history of worsening dyspnea, and found her blood pressure of 230 by 126. And case number two, similar presentation of 56-year-old patient with ischemic heart disease history, diabetes and hypertension, and blood pressure on admission was 170 by 96. So my question is, who has hypertensive emergency? Yeah, let's find out. By definition, hypertensive emergency is significantly elevated blood pressure, and they have included the blood pressure within bracket, systolic blood pressure of more than or equal to 180, and diastolic blood pressure more than 110 to 120. With the symptoms of sign of acute end organ damage, both components need to be fulfilled in order to label it as hypertensive emergency. There is a subcategory called malignant hypertension, where there is significant diffuse microvascular injury in terms of high-grade retinopathy, acute kidney injury, or thrombotic microangiopathic hemolytic anemia with thrombocytopenia. That was introduced to our dictionary in 1928 with an interesting story. At that time, malignant hypertension named in terms of similar medical condition, malignancy, the both had a poor outcome. When we talk about hypertensive emergency, we need to understand what is the pathophysiology behind it. That is best explained with the autoregulation principle. When it comes to autoregulation, they have described this with regard to autoregulation of the cerebral blood flow. Where interesting thing, for the range of from 70 systolic blood pressure to around 160, there is constant blood pressure in our body with the minimal variation. At the two end, if there is some change of that blood pressure can result in either cerebral ischemia due to underperfusion or damage to the brain due to high blood pressure with regard to endothelial injury or cerebral edema. And they have found that even though we talk about this cerebral perfusion and autoregulation, this curve is not perfect for everybody. It is variable. It is variable among one patient to one patient. And not only that, there is, when the patient exposed to chronic hypertension, this curve shifted to the right side. As well as when you treat hypertension, curve again can shift to the left side. And also, if there is high blood pressure, it is not the single reading is matter. That is, the pace of the rise of the blood pressure is the matter. If patient coming with blood pressure of 200 by 120, it doesn't mean anything unless you dig in to find whether this is acute rise or whether it is chronic hypertension. If it is chronic hypertension, you cannot label it simply as hypertensive emergency unless there is new onset end organ damage. And interestingly, they have found that when the patient present with high blood pressure, if you reduce blood pressure by 25%, that patient again come to the range of autoregulation for that individual. And also, if somebody has low blood pressure to the certain level, it can around 30% of the autoregulation curve, it can reduce, it can cause ischemia to the brain. So, for, digging further to the physiology of autoregulation that governed by two theories, myogenic theory and the metabolic theory. Even we talk about these two theories, these theories are variable from person to person as well as organ to organ. Myogenic theory is simply when you have high blood pressure in your vessel wall, the pressure will be inserted to the vessel wall, which consists of smooth muscle. When the pressure is greater, that smooth muscle will contract and make reduce caliber in order to increase the perfusion pressure. That is consistent with law of Laplace. When the radiation of the blood pressure is low, when the blood pressure of the pressure inside the capillary is high, the radiation will eventually low in order to maintain the perfusion. So metabolic theory, on the other hand, is explain how vasodilatation happen when there is inadequate blood supply. When there is inadequate blood supply, there will be accumulation of metabolic products. It will cause decrease in oxygen tension and pH, and it will cause increased carbon dioxide retention, and it will increase osmolality, and it will increase temperature and accumulation of potassium. In certain tissues like myocardium, it will cause accumulation of adenosine, leading to vasodilatation and have adequate blood supply. So moving on to epidemiological data after dealing with the pathophysiology, this is our figures with regard to hypertension. WHO has published this fact sheet in 2021. Nearly 26.2% of our population is suffering from hypertension. An interesting thing here, if you go around 20% of young generation is suffering from hypertension. And when it comes to 60 to 69 age group, almost 60% is suffering from hypertension. Not only that, This is the most important, interesting slide in my presentation. So almost 90% of our population is under control of blood pressure. And not only that, around 40% of the population doesn't know even they have hypertension at the time the diagnosis is made. And there is another study recently published in 2019 that is called Sri Lanka Health and Aging Study, SALAS study, that is community-based study, ongoing study. Based on this 19, they have found similar figures of prevalence of 28.2. In fact, if we apply NIVA's guideline, 2017 guideline, that prevalence even go up to 51.3. And in this study, they have found that 48% is unaware of hypertension at the time of the diagnosis is made. And among them, 16.6% has cardiovascular risk factor or cardiovascular disease and or diabetes. And they have found that this hypertension is more prevalent among urban population and with high socioeconomic status and obesity and Muslim ethnicity. However, sad to say, there are no adequate data with regard to hypertensive emergency at the national level. We don't know our incidence. We don't know our mortality rate. We don't know socioeconomic factors with regard to hypertensive emergency. And we do not know what is the cause relationship when we talk about the hypertensive emergency. However, I went to international figure in the absence of our data. So there is trend of increased hospitalization due to hypertensive emergency in other countries with good inpatient outcome and reduced mortality. Even in better resource countries, the mortality is 12.5 during admission. And also the mortality is 38.9, nearly 40% at the 1 year after the event of hypertensive emergency. And they have found that the mortality even higher when patient admitted with cardiovascular failure or TIA or some aortic dissection. And also they have found that if patient has past history of hypertensive emergency, they have higher mortality risk. So what are the causes or precipitating factors for the hypertensive emergency? And they have found interesting, the most important and single factor that cause hypertensive emergency is non-adherent to the antihypertensive medicine. So it is important us to check every clinic visit whether patient is adhered to the medicine. And other factors I have listed here, it may be drug related like inadequate and antihypertensive doses. And sometimes patient take over-the-counter drugs. It may be iatrogenic. We have started patient on NSAIDs, glucocorticoid, that can cause hypertensive crisis. And it may be treatment-resistant hypertension. I will discuss treatment-resistant hypertension next slide. So it may be related to lifestyle factors like dietary sodium intake and morbid obesity, OSA, and it may be anxiety and panic disorder related factors. And it may be related to the other medical condition like acute stroke and heart failure even can precipitate hypertensive emergency. It is both direction is true. And also renal condition like acute glomerulonephritis, renal crisis can cause hypertensive emergency. And also pregnancy related condition we should not forget. So these are the conditions that can cause hypertensive emergency in a patient with resistant hypertension. That is why history is important. If a patient present with hypertensive emergency, we need to go through the past record to find out whether patient has features of resistant hypertension. If it is the case, we have to dig in to find out whether there are secondary causes such as renovascular disease, primary aldosteronism, whether glucose steroid excess, pheochromocytoma, and coarctation of the aorta. So other precipitating factors in hospitalized patients that we always ignore are the excess intravenous fluid, and giving normal saline can precipitate hypertensive emergency. And also withdrawing antihypertensive for some other reason and we forgot to restart can lead to hypertensive emergency. And also pain urine retention, and even intraoperative period can lead to hypertensive emergency. Let's move into how to evaluate patient with hypertensive emergency. First of all, we need to confirm patient has high blood pressure by demonstrating at least 3 consecutive blood pressure of high more than 180 or 110 to 120 of diastolic. Once you establish that, next thing you need to find out whether patient has end organ damage. If there is end organ damage, it's amount to hypertensive emergency. If there is no end organ damage, that is hypertensive urgency. So how to do blood pressure measurement? When we talk about hypertensive emergency, they have found that using conventional devices and manual blood pressure measurement is underestimate the blood pressure. For better blood pressure reading, we need to have intra-arterial blood pressure monitoring. In fact, they have found that if you use devices, we underestimate blood pressure, systolic blood pressure by 50% and the diastolic blood pressure by 30%. So how to evaluate patient when the patient present with suspected hypertensive emergency with regard to organ damage? We need to go into history and find out whether there are clinical features, signs, and symptoms of organ damage, which include injury to brain, heart, and the large vessels, including aortic dissection. And not only that, we have to think always whether there is features of malignant hypertension as well. And when to do investigation? Are we going to do all the investigation, all the panel of tests, each and every patient present with high blood pressure? For example, if blood pressure present with more than 180, no, that is not recommended. If the patient has features of end organ damage, we need to direct the investigation towards that organ damage and do necessary investigation only. Why it is that? Because they have found that if you do routine screening, anyway, at least 7% of patients who present with high blood pressure can have high serum creatinine. That is because not due to acute hypertension, but undiagnosed CKD due to chronic hypertension. So this is the interesting part of my talk. So what are the gray area of hypertensive emergency? So my first question, does definition of hypertensive emergency need to be changed? Yes. So there is no absolute cutoff for hypertensive emergency nowadays. It is acute rise of the blood pressure rather than single value. If, for example, if young patient presented with first time with blood pressure of 160 by 100 with the features of organ damage, are you going to consider it as hypertensive emergency? Yes. We need to label it as hypertensive emergency. That is what is matter is acute rise of the blood pressure in presence of end organ damage. Second gray area. Can autoregulation principle be applied to all patients in similar way? What if patient has history of myocardial infarction or stroke? Can we use same cutoff? Again, no. We cannot use same auto-regulation principle that we have studied in normal individual using normal population to a diseased patient who has damaged organ. It is variable even organ to organ in an even normal patient. So my second case, this patient, what do you think? Does this patient belong to hypertensive emergency? So my answer is we cannot decide at this point. This information is not enough. So we need to go through past record whether patient has had a good blood pressure control previously. If it is the case, yes, this is amount to acute blood pressure rise presented with acute heart failure. If it is not the case, patient presented with the chest pain with history of good blood pressure control, this is due to ischemic LVA rather than hypertensive emergency. So third gray area, what is the basis for 20 to 25% blood pressure reduction within first hours? This is not clinical base. That is principle for this is auto-regulation that we have studied in individual, normal individual. In fact, there are no studies with regard to what is the best blood pressure control to achieve within initial periods. And what we apply is we assume that 25% reduction will get back to the autoregulation. But it is not studied in the general disease population or inpatient. Fourth gray area, to what extent the cerebral autoregulation is effective. So we talk about autoregulation in that period, blood pressure is maintained more or less same level. No, that is again wrong. Recent study, sprint trial, has shown that if we achieve blood pressure towards even 120, that is towards lower part of that autoregulation, so-called autoregulation curve, has good outcome with regard to cardiovascular risk factors, and even it will reduce the secondary stroke. So can we apply this autoregulation principle for each and every patient? So next gray area, what is the best treatment for hypertensive emergency? Though we manage every day, every week, there are no adequate studies conducted in this part, no randomized control trial done adequately, even the rest of the world. I have made this presentation based on recent New England Medical Journal published in 2019. They have specifically mentioned that there are no enough studies, except for some studies done for the stroke and presented with hypertensive emergency. No other area has studied adequately. And in fact, the current management is basically based on the pathophysiological features and presence of organ damage. What we know and what is our confidence with regard to use of existing antihypertensive medicine. So I'm going back to the story of air crash investigation. So what they do when there is airplane crash, they go into the crash site and they go by one piece to find out what is going wrong. And then they will find this important device called black box, where there are a lot of information, and they analyze each piece of information, and then they will find the answer. At the end, they will make regulations, rules and regulations, and in order to modern safe air travel. That is how they came, that is how air travel is revolutionized. But what is about hypertension? Same paper, WHO published that our target is not achieved. In fact, we are having under control of blood pressure and we are rising the trend. And by 2025, it is only almost 2 years more to go. We haven't achieved our targets. So still today, we are suffering with this problem. Every day we encounter with stroke, 2% with hypertensive emergency, and myocardial infarction, aortic dissection, even acute kidney injury. Are we safe with regard to hypertensive emergency? Similar problem to aircrafts. So my take-home message, even though we talk about hypertensive emergency, it is yet understudied area in medicine, which need more attention in order to reduce both mortality and morbidity associated with it. So these are my references. If you have any question, I'm happy to answer.
Thank you. Thank you very much, Dr. Lankaratna. It's open for questions, first from the physical audience. Anybody like? Sir, you.
There's always a question, when you have a patient coming to hypertensive emergency, significant organ damage, and stroke, how quickly the blood pressure should be released? As you say, there's autoregulation and So not the level of the blood pressure as well, how quickly the blood pressure reduce can affect the endowment coefficient. So what is your advice regarding that?
Yeah, when it comes to strokes, we have two categories of stroke: ischemic stroke or hemorrhagic stroke. We talk about ischemic stroke, that is tricky area. They say that we should not cut down, we should not reduce the blood pressure more rapidly. So in fact, initial period within 1 hour, we can reduce 20 to 25%, but not less than that. So that is because that what we have studied with existent autoregulation pathophysiology, that if we reduce blood pressure more than that, there is risk of brain hypoperfusion worsening the screening penumbra. Yet, this area again based on this pathophysiological mechanism of autoregulation, and we don't have adequate randomized control trial with regard to what is the best blood pressure, initial blood pressure reduction we should achieve.
In the blood pressure, we go by numbers. Are there evidence for looking at mean arterial pressure versus systolic blood pressure? Or you look at systolic blood pressure? Looking at the diastolic blood pressure, how it drops. Is there other studies looking at mean arterial pressure versus systolic blood pressure drop?
No, sir. For my extent, I have went through several articles. They haven't studied. They have suggested that intra-arterial blood pressure monitoring is better than the device used, but they haven't mentioned, they haven't compared whether it is systolic blood pressure is better than the mean arterial pressure.
Autoregulation comes from the diastolic blood pressure.
Yes. Yeah.
And the other thing is there a safe low limit of blood pressure? For example, you start out demo treatment, or when you tell you start this anti-hypertensive, and you should tell this is your target, you should not go lower than this. If there are target of safe low limit of blood pressure.
Unfortunately, again, sir, no. There is what they have mentioned is within first hour we need to reduce 20 to 25%, and then afterward, preferably up to 160 within next 6 to 12 hours. Then below that, they haven't talked about what to do. Again, everything, each and every these suggestions are coming from this physiological mechanism rather than doing randomized control trial.
Question from the virtual audience.
Two quick questions from the virtual audience. One, I think probably you answered this already. If this 25% is theoretical reduction, what is your suggestion of blood pressure reduction in hypertensive emergency?
My suggestion, that is why I choose this
to our audience to do some studies. We have a lot of resources. We have a lot
reduction we should achieve. Even my level, I don't have any suggestion, but I am going to do even what we have is the recommendation by the guideline. So guideline recommendation is 20 to 25% reduction. I have to stick with that. But if we can have more and more randomized control trial, it is better for future change.
Question, is there any place of oral drugs in this emergency hypertensive?
No, that mentioned in guideline that if you diagnose with hypertensive emergency, better to admit patient to a medical ICU and start with intravenous drugs.
And also to say, when we say the end organ damage, that as you said, there can be previous end organ damage. So how we really define it's new symptom development or finding a new damage?
Yes, again, sir, by end organ damage need to be determined by going through the history examination and the directed investigation. In history, we need to ask symptoms, whether there is significant features of end organ damage. Even hypertensive urgency can present with atypical chest pain. Does not amount to hypertensive emergency. If patient present with acute severe headache that you think it is not consistent with simple hypertensive urgency, that you need to do the rest of the examination with assessment to us to find out whether there are focal neurological signs. If in that case, you need to confirm with NCCT brain to see whether there is ICH. So that another example, if you suspect this high serum creatinine is not due to acute kidney injury, you need to go through the past record and find out whether there is high serum creatinine. So that decision is not simply based on single factor, but connecting all the available information together. We need to decide clinically whether this is acute organ damage or pre-existing organ damage.
So in absence of any further questions, thank you very much, Dr. Lankaratne, for that excellent presentation. We have a certificate of appreciation for your participation here.